Good evening. I'm delighted to be here with you this evening, and welcome to our webinar on racism and bias in medicine, a critical condition. This event is being co-sponsored by the Atlanta Medical Association, the Emory Department of Medicine Diversity, Equity, and Inclusion Council, the Emory Urban Health Initiative, and Georgia Gear. Our moderator this evening is Dr. Frank Jones, who is the president of the Atlanta Medical Association. I am Dr. Jada Bussey Jones. I am a professor of medicine and vice chair of diversity, equity, and inclusion for the Department of Medicine and the director of education for Emory's Urban Health Initiative. I'm delighted to be here with my panelist, Dr. Gatekeepers IV, who is a cardiologist and a professor of medicine and vice dean for faculty affairs at the Ohio State University College of Medicine, along with Dr. Kimberly Manning, a professor of medicine and associate vice chair of diversity, equity, and inclusion for Emory's Department of Medicine. She is also the transitional year program director for the J. Willis Hurst Internal Medicine Residency Program. What we're hoping as panelists is that by the end of this session, you will be able to first define the concept of unconscious bias and its important impacts in clinical spaces and in the workplace. And importantly, we hope that you'll be able to list some strategies to mitigate the impact of those biases, both as a clinician and as a bystander. And finally, we want you to be able to describe one powerful example of a structural approach to change the workforce. This slide here reminds us to acknowledge how difficult this discussion is. It's heavy. We are grieving with all of the events of our recent past. We also know that the United States is becoming more diverse and that by 2050, that whites will no longer make up the majority of our US population. Also, while these issues have been around for centuries, they've been highlighted recently in the media. And importantly, it's important to talk about these issues because it has a significant impact on our patients, our community, our learners, and our colleagues. So we'll start with defining implicit bias. Implicit biases are attitudes or stereotypes that impact the way that we think, what we understand, and how we act, and the decisions that we make in an unconscious or implicit manner. It's important to know that these things are pervasive. They're in the air we breathe. They impact every single one of us, whether we are out marching for Black Lives Matter or whether we are giving a bias and racism seminar. We all have these biases. They do not always align with our declared beliefs. So again, if we are speaking against racism and bias against gender or race, we may still have implicit biases against women or people of color. And so even though we express the opposite view. Similarly, our biases generally, but not always, align with our own in-group. So that as a woman of color myself, you might think that I might have a preference for other women or other people of color, but that's not always true because I, like others, receive the same societal messages about those groups and may internalize some of those biases against my own in-group as well. Importantly, our biases are malleable, but unfortunately not that much. You're not likely to go from one end of the spectrum to another, but there are ways with intentional effort to reduce the biases that we have. But even more importantly, because these biases are so ingrained and indoctrinated over time, and it's less likely that we will have major shifts in our biases, we can find ways that we can change what we do rather than what we are thinking implicitly. So while we are not born into prejudice, we do learn it very early in life. Researchers have found that by 3 months, infants begin to demonstrate a significant preference for faces from their own in-group. And it starts early in life, as we mentioned, but it becomes cemented over time. This image, for example, of a Google search for the term boss, or looking at the pictures of our last US presidents, these images provide a clear and consistent message about who leads. And you can imagine, for example, if a person took a new job, moved to a new neighborhood, started a new school or a training program, these kinds of images, oil paintings on a wall in an organization, sometimes give the identity and the clear message that some, more tthan others, can assume acceptance, inclusion, respect, and opportunities. If we move to medical care, we can look at an Institute of Medicine report that in 2002 showed that across healthcare, Blacks in particular, but minorities in general, receive fewer procedures and poorer quality medical care than whites. And that these differences persist even when you control for things like insurance status, socioeconomic status, disease severity or comorbid conditions, and they persist even in situations where you think the care should be fairly similar. So patients who all have Medicare or who are all at VA facilities where differences in economic status and insurance coverage should be mitigated. But also, as you can see from the picture here, that these are one study where they had patient actors who were portraying a role. They had the exact same script. You can see they're all dressed in hospital gowns, have the same background. And they showed these videos of these patient actors describing their chest pain story to large groups of doctors and asked them to make a diagnosis and treatment plan. And they found that their treatments differed based on race and gender, even though objectively they were listening to and seeing the same information. This next study I like to talk about because it also includes some of our trainees at Emory University. So this was a study of 300 internal medicine and emergency medicine residents from 4 academic hospitals in both Boston and Atlanta. And they had the residents look at clinical vignettes of Black or white patients who had acute coronary syndrome or chest pain. They asked them a questionnaire that asked them about their explicit preferences for one race or another. They also had them take that implicit association test that I talked about earlier, that validated instrument to explore implicit biases. And so what they found was that the residents expressed no explicit preference for one group or another. That's perhaps not surprising, but on their IAT, there was an implicit preference that favored whites over Blacks that was statistically significant. And importantly, as their pro-white bias increased, so did their likelihood of prescribing or treating with thrombolytic therapy for whites and not treating Blacks. So this one was the first study that really showed not only the biases that we have, but that those biases can impact the clinical care that we give. So it's really hard to think about this study in a major way without sort of feeling some pain about that, because I think we're all really well intentioned. And I like to make the analogy that it's similar to how we think about policing in some ways. And I know not all police officers that this applies to, but I really do feel that most police officers don't get up in the morning saying that they're going to intentionally harm someone, shoot an unarmed Black boy. And likewise, we as physicians don't intentionally treat someone differently because they are purple or green or polka dotted. But the impact that our police have, and even that we have to think about really can have an impact in terms of life or death. And so Michelle Van Ryn and her colleagues provide this evidence-based framework that really can tell us how race and other characteristics can impact not only how we hear patients, how we interpret their symptoms, but also how we interact, how much information we give to them, how much physical exam that we do. She provides, research and resources on all of this information. But most importantly, it can impact the treatments that we give. She describes it often that we may make assumptions about patients, about their adherence to therapy, about their social barriers, and that may in turn lead to, for example, assuming that the patient doesn't have transportation and saying, I'm not going to put them on the transplant list. Or assuming that the patient might be non-adherent and saying, I'm not going to offer them antiretroviral treatment. So these decisions can have life or death implications for our patients. So if we turn from the clinical space into the academic or into our workspaces, I'm just going to show a couple of examples here. So one example in an academic facility where they looked at resource allocation, they asked science faculty, both men and women faculty, to look at students who were applying for a lab manager position. And this was a made-up case, so they had a CV or a resume, maybe a cover letter that was exactly the same. The only thing that was different was it was given either a male name or a female name. And they asked the faculty to judge the students in terms of whether they would hire them, whether they thought they were competent, and whether they would mentor them and how much salary they would assign. And so what you can see is that there were differences based on gender, such that there was a preference for the male students. And that was particularly true when it came for salary.
And interestingly here, that both the male faculty and female faculty rated the male students higher. So again, this internalized idea of women in particular here that that sort of talks about the hireability and the competence of males over females in this situation. A similar study looked at same CVs posted on several job sites. In this case, even though objectively they were the same, they just gave them different names. Some that sounded prototypically white, like Emily or Neil, versus prototypically black sounding names like Aisha or Tyrone. And they found that there was a 50% callback that was attributed to those name changes. So I think the question is kind of how we think about this. Oftentimes we think about diversity initiatives as something for those women, those people of color. I think that for our organizations and our departments and our institutions, we have to really begin to think about this as a core strategy and a value for everyone, the implications for everyone. And there's lots of information in our business space, work in research in the business environment that shows that there's considerable return on investment. I often make the argument, I used to and I still do, about sort of the moral reasons for doing this, the justice question, social justice, but I think the framework can also be made about the business side of it. In the business space, they found that the more diversity that you have, there's more improvement in the bottom line, higher innovation, more organizational flexibility, and better recruitment. And so sometimes those arguments may be helpful for some of our other stakeholders as well. In the clinical space, there's evidence that Black patients are more likely to get preventive services when they're cared for by Black physicians, that female patients are less likely to die after a heart attack when they're cared for by female physicians. And even though so far there's less evidence, clear evidence that either Black physicians or women physicians are more or less biased than other physicians, there's clear evidence that patients prefer race and language concordant relationships, and that it's associated with higher ratings of satisfaction, higher adherence to therapy, and trust, and therefore can be assumed to have higher improved outcomes. So for all of us, as we're thinking about our individual patient encounters and even our encounters with colleagues, we might think about a couple of things that have been suggested in the literature about how we can mitigate our biases. So one is around counter stereotype imaging. And so here we mean seeing the individual as the opposite of the stereotype. So if you can imagine the patient who is homeless, the male or female, instead of seeing him or her as a homeless person, that you imagine him as a CEO of Apple, or the CEO of Home Depot and our Atlanta native. So if it's Arthur Blank in the bed, the conversations and the way you talk to him might be different, or the order of the tests that you do for him, or the treatment that you give. And so we'd like to think that that's not the case, but based on the evidence that I've shown today and other evidence, that it is probably true. And so this has been one of the tools that we can use to kind of mitigate our biases. The other two examples are common identity formation or individuation. And these are really sort of seeing the person as an individual, humanizing the individuals. Again, if we use the analogy of policing, neighborhood policing, where you know the community as opposed to policing from a precinct. So instead of the diabetic in room 24, if you know more about the person's family, their background, and other things, that can mitigate some of the biases. I find this particularly helpful in patients that I'm struggling with, especially some of our colleagues who do trauma-informed care, that when you take time to understand their stories, that can really impact how you engage with them moving forward. And then finally, perspective taking. And so this is kind of treat others as you'd like to be treated, putting yourself in the other person's shoes. This has been studied specifically with nurses. There are studies that suggest that patients, particularly Latinx and African-American patients in the emergency room for an acute long bone fracture, receive less analgesia in that time frame. And so if you ask the nurses, how would you want to be treated if you just broke your femur, that has been found to mitigate and improve their response to analgesia for all patients. And so that's just one additional technique. And so finally, I would just say in summary, before I turn it over to my colleague, Dr. Manning, that we know that individual biases exist. And unfortunately, these biases are influencing our professional encounters and our clinical encounters. And so we have to be active and intentional about these things. And I'm going to turn over to Dr. Manning, who will talk about being a better bystander as one additional strategy to mitigate some of our biases and some of the racism and bias that happens in clinical care.
Thank you, Dr. Bussey Jones. And thank you so much to everyone who's taken the time out this evening to be here with us. I saw a question that popped up in our Q&A asking, what can we do? And so this will be the answer to that question for you. What can we do? How can we move from hearing about these things and knowing what to actually do in real time? So I'll start with a story. A patient had a major surgery and was post-op, had tolerated the surgery well, and the surgical team comes to make rounds on the patient. The team is made up of an attending physician, made up of a senior resident, 2 interns, and 2 medical students. Every single member of the team was wearing hospital-issue scrubs, white coats. The medical students had short white coats. And one of the students, as they approached the bed to get ready to see the patient's wound, had the patient look at her, push her tray over to her and say, "I wasn't very hungry, you can take this tray away." The whole team looked just the same, except the one difference is that this one individual, this one student, was a Black female. Now you might imagine that in that minute, someone immediately corrected that patient and said, "No, she's a member of our team, she's a medical student." In fact, the student had to speak up for herself and say, "No, I'm actually not a member of food services." And again, there wouldn't be nothing wrong with being a member of food services. And no one said anything. And so as the student stepped out into the hallway with the team, no one ever came to her rescue and was never discussed. They just went on rounding. And that student would then sneak away to a stairwell where she would weep and call me, who was her advisor at the time, to unpack this. And this is really an experience shared by many people who are underrepresented in medicine, this othering where things happen under the radar, where maybe the intention was not to be hurtful, but again, it is. And so you might wonder, why didn't anybody on the team do anything? Why didn't that attending jump right in and say, "Hey, wait a minute," or her co-student, or even her interns, people who she'd been working with for the entire month? That really is because of something that I'd like to introduce to you called the bystander effect. And the bystander effect says that whenever there are more people there, the more people present when something happens, the less likely we are to act. In fact, if it's just you, when someone has a cardiac arrest, you're about 85% likely to act, but that falls down to 31% or even less as other people show up. And so that's probably what happened in this instance. And so why? The first being diffusion of responsibility. I mean, somebody else is going to act. I mean, maybe the co-student said, "My attending didn't say anything. My senior resident or interns didn't say anything. Who am I to say something?" So that diffusion of responsibility. Ambiguity. Wait a minute. Wait, was that wrong? Was that something that was that not okay? Maybe it was an innocent mistake that the patient made. Maybe I'm just overreacting. So sometimes that can paralyze people. Perceived cost. We certainly know that in medicine, it's hierarchical and has been traditionally. So imagine if that co-student felt moral distress and wanted to do something, but perhaps confronting someone in the real time might be something that could hurt her grade in the future, or maybe she wanted to be a future surgeon at that program. So that might muzzle her as well. And then there's just an overall apprehension. Some people like a good confrontation. I know my sons seem to, but many people don't like confrontation. And oftentimes being a bystander, or as we like to refer to it, a better upstander, really calls for some kind of confrontation. And sometimes people don't act because they didn't even see what happened. And, you know, I think many underrepresented minorities will tell you that the most hurtful piece in all of it is that nobody seemed to see. And is it because somebody is really out to be unfair to you or racist? Or is it just that their life lens and how they came up and their exposure to experiences has caused them to have a blind spot to miss what is hurtful to you, a colleague, or a patient? So I'll give you as an example this. So this artist here, this man singing, is somebody that up until probably I was a full grown adult, I had no idea who he was. Well, as it turns out, in my internship, we all went to a dueling piano bar in downtown Cleveland, Ohio, where we were all listening to this music and people playing live music. And then the dueling piano singers start to play the first few bars of a song by this man, who I have now learned is named Meatloaf. And every single person in that entire bar jumped to their feet, sang at the top of their lungs every word to a song that I'd never heard in my entire life. And that is really more because of my life lens, right? My life lens is I'm a Black American woman who's a descendant of slavery, who's from Inglewood, California, who went to 2 historically Black colleges, Tuskegee University and then Meharry, steeped in Black culture my entire life, and none of it included Meatloaf. And so the same could be said about some of the experiences and things that we see day to day in the hospital. Maybe it's just a blind spot. Maybe it's your theoretical Meatloaf, right? And so I'd like you to take a moment to think a little bit about, much like Dr. Bussey Jones was mentioning before, thinking about others' shoes. So this is an exercise that I like to do, which is good for me as well, where you take a moment to think first, what are 3 things on this list that I always have to think about every single day as I walk through my day? For me, I always think about the fact that I'm a Black American. I always think about the fact that I'm a woman. I always think about my husband's safety. I'm married to a Black man. I have 2 Black teenage sons. I always think about my loved one's safety every single day. Now, conversely, if I think about some things that I don't have to think about, sometimes I never ever have to think about my religious expression. I don't think about my gender identity or gender expression. I don't really think much about my name. It's pretty easy for people to say it's phonetic. I don't have to worry about the microaggression of having my name mispronounced or challenged or explored by someone in ways that make me uncomfortable. So I ask all of you to just take a moment to think a little bit about this as well. Now, some of these things lead to what we call microaggressions. And I'd like you just to take a moment to listen to this for those who don't know about microaggressions.
For people who still don't think that microaggressions are a problem,
Oh, you're so well spoken.
just imagine instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland.
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins name. It's part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up
Do you
everywhere.
know John? Give me shopping advice.
So
I
bad.
love share too.
And getting bit by mosquitoes every damn day,
Can I touch your hair?
multiple times a day,
So pretty.
Can I touch it,
hair?
please? Can I please?
is annoying. And makes you want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares? Just another angry Black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
It looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
They always explain it much better than I can. So
For people who still don't
excuse
think,
me. So as we move along, now let's think a little bit about, as we understand what microaggressions are, and we think about why we perhaps don't respond right away, how can we move from understanding things to actual change. This was a study that was written and published in Academic Medicine in January of 2020. And it applied something called the transformative learning theory to the idea of taking the things that we learn about implicit bias and moving them to change, which is a big part of why we're having all these conversations now and what we're hoping can come from all of this momentum. The transformative learning theory, I should mention, is not a new concept. It's something that was described back in the 70s for the first time, but really applies well here. And let me share with you a little bit about why that is. So the transformative learning theory has a few steps. The first being a disruption and revised interpretation of a situation. So as we think about implicit bias and racism, perhaps for you, that disruption and revised interpretation happened through seeing a video of a man underneath a police officer's knee, right? Maybe it was through watching that video just now, but the goal of transformative learning theory is to start by a disruption. Then comes critical reflection. You heard something, you saw something, you think something different, and then dialogue, which is a critical piece in all of this, and ultimately action. And so many people take pause at the word microaggression and think, can we use another word for it? It suggests that it's on purpose. It sounds like an assault. And I actually agree with the part about it sounding like an assault, but allow me to ask you to look at it a little bit differently. See the word microaggression as an opportunity to be disrupted, to understand that the death of 1 million paper cuts, which many of your colleagues and patients are experiencing, is just that. Though not on purpose, it can be just as damaging. And so this disruption and things that we're seeing are critical to us taking the next step. So we've learned so far about the bystander effect and how the more people that are around, the less likely we are to act. We also recognize that in addition to that bystander effect, we have varied life lenses, right? Some people know all the words to Meatloaf and some people know all the words to Notorious B.I.G. That would be me. And then there's the transformative learning theory, right? That moves us from that disruption into change and action. And so what do we actually do when these things pop up? We have to notice, evaluate, and then assume responsibility. Now, some of you have heard of different approaches to being a better bystander or upstander, the 3D approach, the 4D approach. But today I'd like to introduce you to what we call our 5D approach. The first being to just be direct. You see something, someone accused the medical student of being the food services person, correct them gently and say, this is a member of our team. Distraction, maybe it's so uncomfortable that someone says, hey, let me just change the subject and get us to talk about something else. You can also delegate, where you go to someone senior, perhaps her co-student was to go to the attending or to a dean and say, hey, this is what I witnessed and this was not okay. Or delay, you saw something happen and in real time, you may not have been comfortable to say something, but then you go back to the individual and say, I saw what happened. I want to check on you and make sure you're okay. But if you talk to a lot of people who've been on the opposite end of microaggressions, many will tell you that one thing that's often missing is this: just a display of discomfort, just this acknowledgement that I saw what happened, that was not okay. But this normalcy that oftentimes is felt in these moments is one of the most painful things of all. So we make that our 5th D to call this our 5D approach to upstanding. And so what does display of discomfort look like? It could be just as simple as keeping your face straight and not laughing. You can get a little dramatic with it. You can get even more dramatic with it. And if you feel strongly, you can make it very clear. Even if you don't have words to say, know this: if someone knows in real time that they are not crazy and that somebody else saw what happened, that in itself is a form of upstanding as well. And so just to repeat again, because we like to make it stick, remembering that there's that display of discomfort. I show that in a different color because I think we all can do that regardless of what your personality is like. Direct, in the moment intervention, distract, shift the focus, delegate, speak to someone, document it, tell someone what happened, or delay, check in later. Now, your homework in this is really going to be a few things, because really for any of our learning to stick and for us to have that spaced learning, there has to be a plan and some action. And so first, I'd like to just make sure after this is all over, tomorrow, whenever, you reflect on that list of things you do and don't have to think about every single day. What is it like for those individuals that do have to think about those things? Imagine what that's like and make a list of those 3 perspectives that you never have to consider. And then the more difficult part for all of us is to recognize, hey, you know what? When was there a time that I witnessed or committed a microaggression, and what could I have done differently? How would I apply those 5 Ds, excuse me, in that situation? And I'll add as a last little piece in there is that these 5 Ds can apply to you standing up for yourself. Sometimes if you are on the opposite end, you can apply one of those 5 Ds to be your own upstander. And also, if you are the person that has committed the microaggression, you can apply those 5 Ds, but with an auto correction by making sure that you, whoa, stop what you're doing, or even consider a delay and going back and saying, I acknowledge that I said something that wasn't okay. So never miss the opportunity to take that on. I'd like to shift our gears now to my esteemed colleague, Dr. Capers, the fourth. Dr. Capers, you're muted.
Thank you. Thank you. Thank you, Dr. Manning. Thank you, Dr. Bussey Jones. And I'd like to add my thanks to everybody for tuning in. It is a tremendous honor for me to be sharing this panel with Dr. Bussey Jones and with Dr. Manning. And so we're really glad that you're here. We're here to unequivocally state that racism is a disease. We're doctors. And as doctors, we're here to fight disease and try to prolong life. And we're making the statement that we can't truly prolong life and improve life for all of our patients unless we, as physicians, take on racism as well as these other diseases. Now, I'd like to make a statement here that the legacy of racism in medicine and bias in medical school admissions goes back a long way and casts a long shadow. And here is a document from right here, Atlanta, Emory University. You're looking at a letter from the admissions office dated 1959 to a medical school applicant. And it says, "Dear Mr. Hood, acknowledgement is made of your letter of July 30 enclosing your application for admission to our School of Medicine. I'm sorry I must write you that we are not authorized to consider for admission a member of the Negro race." Now, you and I know that Emory was not the only medical school in 1959 that had this policy. In fact, if anything is unusual about this, it's that they put it in writing, right? I mean, you know, usually a medical school will be smart enough to have this an unwritten policy, but here they put it in writing, and as it does, history has a way of declaring itself. So if you think about how many medical schools had this policy, we think about even then, as Dr. Bussey Jones has already stated, Blacks tend to play an outsized role in treating underserved, disadvantaged, and vulnerable populations. Policies like this have had a tremendous impact on the health of a nation, particularly the health of our community. Now, we can fight this, and there is an antidote to racism and bias in medicine that includes having an enlightened society, all of us opening our hearts and minds to one another, but it also things like holistic review and implicit bias mitigation in medicine, and specifically in medical school admissions. We have a physician workforce that does not even come close to reflecting the diversity in this wonderful country of ours. And we know what the culprits are, and that's always important to list the culprits so then you can go on to action items. And the culprits include a supply chain or pipeline that is very leaky. There are low numbers from really elementary school to high school, all the way up to medical school. I like to think of the kindergarten to medical school pipeline, and that pipeline is in bad shape with major leaks throughout the pipeline. And also a lack of visible role models. But there also is a culprit with people that I like to call the gatekeepers. So if you think about that pipeline from kindergarten to medical school, there are a lot of gates that you have to get through. And those gates are tended by gatekeepers. And I like to think about engaging those gatekeepers. So getting into college, you've got to get through that gate. Getting into medical school, getting into your residency, there are keepers of the gates. So admissions committees, program directors are the gatekeepers, and they have a role to play in shaping our workforce. And finally, in academic medicine and in training physicians, There is unconscious bias, as you've heard about from the previous two speakers, and there's a lot of inertia. I spend a lot of time talking with people about how to diversify the programs, and occasionally we see strategies that are not only neutral, kind of anti-diversity. And a very often answer that I hear when I ask someone, why are you doing it that way, is we've always done it that way. We never thought about doing it a different way. So some of this is structural and passed on from program director to program director to program director, or admissions committee member, you name it. So those are the culprits. And what I'd like to do is share with you now a little investigation that we've done. So I have the honor of sitting on the American College of Cardiology's Diversity Task Force. Our specialty is not very diverse. And so we want to try to change that. So one of the things that we're working on in my work group is trying to get into the minds of the gatekeepers, the program directors. And so we surveyed cardiology fellowship program directors around the country. We got 110 respondents, and you see here the breakdown between general and subspecialty adult cardiology. One of the questions on that survey was this: which statement most accurately describes your position with respect to increasing diversity in your program? And we gave 3 choices. 21% agreed with this statement: we want to increase diversity, but we don't know how to do it. 18% agreed with this statement: we want to increase diversity, but we got it. We got this figured out. We have a plan. Thank you very much. 61% agreed with this statement: we're good. Our program is diverse already, so diversity does not need to be increased. And so let me share with you that in cardiology, only 13% of practicing cardiologists are women, 5% are Hispanic, and not even 3% are Black or African American. And so in a specialty with 13% women, 5% Hispanic, and not even 3% African American, 6 out of 10 program directors say we're diverse enough already, and we don't really need to think about enhancing diversity. We also wanted to get inside the room. So recently took my family to see Hamilton. We loved it. And my wife is playing on a continuous loop in my house, that soundtrack. And so that one song, you have to be in the room where it happens. So we think about that in that room where the rank list is made. It's usually a closed door. I like to think of it as the cigar smoke filled back room where the decisions are made. So to get a view of what's happening inside that room, we asked a question. And what we did was we provided 10 characteristics of cardiology fellowship applicants, and we asked the respondents to rank them according to what they consider most important when they're making their rank list. Number 1 on the list was clinical skills. Got no problem with that. Number 2 was ability to fit in well. So think about that, ability to fit in well, and I wonder if that means the same thing to me that it does to you. Number 3, research productivity. Next was strength of the program director's letter. USMLE scores, standardized test scores, was number 5. Prestige of the academic medical center, number 6. Number 7, communication skills, number 8. Potential to be an academic leader. Number 9 on a list of 10 was being a humanitarian when we're choosing heart doctors. But guess what was number 10? Diversity. Diversity, or the ability to enhance the cultural competency of the program, is literally the last thing on the minds of program directors and associate program directors when they are making their rank list. So this is important information that we can use. So we've come up with what we call the ABCs of diversity enhancement. It can be quite simple. It does seem at times that we make it harder than it has to be. We need to reach back into that deep pipeline, and I'm talking 4th grade, 5th grade, 6th grade. We need to mentor relentlessly, pre-med students, medical students, be visible. Being a role model is so important to those who are underrepresented in medicine. They need to see us. Now, you and I can't be everywhere at the same time, so we're actually a big advocate of using social media to expand your visibility. Number 4, encourage your mentees to enter academic medicine. I love private practice. My first 8 years as an attending, I was in private practice. And wonderful things happening in private practice. In academic medicine, though, you're surrounded by trainees, and there really is more of an ability to have an impact. So you have some mentees, see if you can nudge them towards academic medicine. Number 5, confront implicit bias. Number 6, engage those gatekeepers. Number 7, what if? What if we made diversity / ability to enhance cultural competency, what if we made that a top 3 priority when we're making our rank list? How might that impact diversity in medicine? And then apologies to Nike, but number 8, I say just do it, because we've been talking about it for a long time, and now it's time for action. So let me end now with showing you some examples of how these strategies really can work. So at The Ohio State University College of Medicine, we have so many outreach and community engagement programs that go down from high school down to elementary school. And you're looking here at students who attended our Saturday heart school, where they got to dissect a heart proctored by minority medical students and minority faculty. And they're showing you their diplomas. They graduated from heart school, so they now know cardiac anatomy, they know a little bit about CPR, and they know what a heart attack is. I want you to pay attention to this young man here, this 4th grader with his arms folded, and I tease him because he lost his diploma. This is him as a pre-med student at Northwestern University. And this is him as a first-year medical student at The Ohio State University College of Medicine. We call this growing your own garden. So all of us have a responsibility to reach back and go back deep into the pipeline. As I like to joke, I don't know how many 4th grade to medical school cycles I have left in me, but this is very satisfying, and this is something that we can all do. Number 2, mentor relentlessly. We have a quarterly African-American male mentoring roundtable where we get our male, African-American male attending physicians and medical students together for dinner, for socializing, for counseling, for advising, and just to make sure these young men are on their way to success. We know that in a few years, we're going to have a crisis shortage of Black men in medicine. And so we all have to do what we can to make sure that the few we have in the academy are on track for success. Be visible in person and social media. So I'm on Twitter, and I know that a lot of you are too. You might have seen this hashtag, Black Men in Medicine. Several years ago, several Black male physicians and myself were lamenting the shortage of Black men in medicine and thought, what can we do to combat this? And we came up with an idea. What if we absolutely flood social media with images of Black men in medicine? There would be 3 objectives. Number 1, we would encourage youngsters. Number 2, we would speak out against injustice. And number 3, maybe, just maybe, if we flood the airways with images of Black men as doctors, we can change the nation's unconscious bias about Black men from Black man equals danger. Maybe we can make it Black man equals physician. So we encourage all of you on Twitter to use this hashtag Black Men in Medicine to promote diversity in medicine and to promote an end to racism and bias in medicine. As we say, you don't have to be Black, you don't have to be a man, and you don't even have to be in medicine to use this hashtag, and we really want you to do that. Here's an example of some of the photos that we put out under that Black Men in Medicine hashtag, and this is after one of our African-American male mentoring roundtables at The Ohio State University. Number 4, encourage mentees to enter academic medicine. Meet the cardiologists of The Ohio State University. If you know another academic medical center that has 8 Black men in the same section of cardiology, I don't think there are too many that fit that. But this, I want to make the point, does not happen by accident. This is not an accident. When you truly believe that diversity improves care and diversity saves lives, then you break out of the inertia to do things differently so you get results that look like this. Number 5, confront implicit bias. What we've been doing for several years now is we've put together an implicit bias reduction cheat sheet, we call it, so that on medical school interview day, our medical school interviewers, in addition to reviewing all of the information about the student, this is one of our interviewers, Dr. Michael Kakovic, he actually is cramming implicit bias reduction strategies minutes before going to get the candidate to interview. This can very easily be applied in the GME setting as well. Number 6, engage the gatekeepers. These are the gatekeepers. So cardiology fellowship program directors have an annual summit at the Hart House in Washington, D.C. And here we're having a case-based, vignette-based, implicit bias reduction workshop. So we have to engage those gatekeepers. What if we made diversity / the ability to enhance cultural competency a top priority when making a rank list? In our interventional cardiology fellowship training program assessment, we've done just that. So what I'm showing you here is our actual list that we use when we are evaluating our interviewees for our interventional cardiology. We rate them in 5 spheres, one of which is diversity or their ability to enhance the cultural competency of our program. So there was some mild pushback when I was the program director and instilled this, because we had people say, Quinn, we're trying to pick physicians who can thread a wire the size of a thread down the LAD, across the diagonal, and across that severe blockage, or people who have the manual dexterity to stick a long needle into the pericardial sac, or people who have the skill to put someone who's dying of cardiogenic shock on ECMO and do an angioplasty within 5 minutes. What difference does it make? What difference does it make if their letters of recommendation cite diversity or cultural competence as a trait? What difference does it make if they've been exposed to different cultures? What difference does it make if they've been exposed to patients from disadvantaged background? This is not what you should be looking at when you're choosing candidates for a procedural-based specialty. And my pushback to that pushback was, if you are serious about ending healthcare disparities, then it is exactly what you should be looking at. We're proud to take on implicit bias and use holistic review at our medical school. We're moving it to our GME programs, and we've got results. So using some of these results, we now are one of the most diverse medical schools in North America. Every year, U.S. News and World Report for the last 5 years ranks the majority medical schools, which is 152 in number, ranks them according to the number of enrolled African Americans. So when you exclude Howard, Meharry, Morehouse, and Charles Drew, that leaves 152 medical schools on that list. This year, we are number 4, tied with UCLA for schools with the most African American medical students. And I know the admissions dean at UCLA, he's a friend, and I tease him. I say, do you mean to tell me we are just as successful at convincing Blacks to come to Columbus, Ohio, as you are to Los Angeles, California? And he doesn't like it when I tease him that way. But the point is, the students will go where they feel supported. And so we're proud to be on this list. In summary, lack of diversity in medicine can be harmful to our patients. We know that. Enhanced diversity can improve patient communication, compliance, trust, and save lives. Enhancing diversity is among the strongest anti-racism strategies that we can do as a medical profession. The time has come, ladies and gentlemen, to consider diversity in medicine a mark of excellence for which stakeholders will be held accountable. Thank you very much for your attention.
First of all, again, let me congratulate all of you for excellent presentations. And what we want to do now is really have an interactive discussion. And we will be using the Q&A portal where the chat is not active. So if you have a question, and please send us some of your questions so that we can answer them. I see we already have a few there. Let me see. Is it possible? How might it be viewed if one is not a Black attending and be a mentor for a Black student who you have connected with? Okay. So is it possible to, or I guess I ask, how are you viewed? So if you're mentoring, if you're not Black and you're mentoring a Black student, Dr. Capers, is that possible?
Absolutely. In fact, I'm so glad you asked that question, because one thing I tell my mentees is that everybody that is a mentor, advisor, or role model to you doesn't have to look like you, right? And you know what I say is that it actually is important to have a team of mentors, a panel of mentors. You might have a mentor that regarding your research career. You might have a mentor regarding what you want to go into clinically. You might have a mentor that helps you with your work-life balance. So you should really have a team of mentors, and actually having diversity amongst your mentors is actually a very good thing.
Can I add
And
to that too? I just like to add to that for many of us, our mentors don't look exactly like us. It's a missed opportunity when students, or when we guide students, to believe that they have to find an exact matchup for their mentors. Like Dr. Capers mentioned, I have a panel of mentors that help me with the things that I need. Some are project mentors on very specific things, but ultimately for any way that you're going to win, whether that be a coach, whether that be a sponsor, whether that be your formal mentor, it has to be somebody who cares about you. So when you meet up with your mentor, don't so much focus on whether or not they look like you, but whether or not they care about you. Are they interested in you? Are they looking for ways to help you succeed? Are they making the time for you? Is it impossible to get on their calendar or not? People who care about you and who want to see you succeed, they can look many ways, but go with how you feel and the kind of attention that they're giving you.
And I wanted to add one other personal story really quickly about this, a little anecdote that even though I had been taking leadership roles across my career over time, I had never asked for a raise. I had received some, but had never asked for any. And so when I became the chief of my division and saw the salaries all over the place, there were people who had been here less long, less time, not in leadership roles, that were making more. And so it was shocking to me. So first I decided that I was going to change the compensation plan, but it really sort of made it clear to me, number one, how to be more equitable in that space, because people like me may have imposter syndrome or other reasons why you don't ask for raise, and that shouldn't necessarily be a factor there. But I also learned, when I did have a white male mentor, which I do now, that my approach to getting leadership roles and how I negotiate that is completely different through the lens of that person than I had in my own experience. And so I think that not only, as Dr. Manning said, you want someone who cares about you, but it can really be impactful to have a different lens, as she described earlier, as you're thinking about your career choices, the support that you need, and as you're going through that mentoring from a different perspective can be incredibly important.
Okay. I just have to briefly put in a plug for an event that we're having next Tuesday. I have a mentoring program called Pre-Med Solutions, and in conjunction with the Atlanta Medical Association, we're having a huge virtual boot camp mentoring program. We have 12 of the top medical schools admissions officers from around the country that are going to be participating in that. And so if you're in the audience and you know some students, minority students, they don't have to be minority students, but particularly minority students, if they're trying to go to medical school, they would want to be on this webinar next Tuesday, and we can get you the information for that. And it's going to be next Tuesday, Pre-Med Solutions Bootcamp. We see the questions are starting to add up here. Let's see, recently 2 of our Black physicians left academic medicine. What are some of the ways that we can help retain diversity?
So I'll start off with this one. I think this is not uncommon. The evidence supports that the turnover rates amongst African Americans. So in Atlanta, for example, at Emory, our rates of diversity are actually probably better than the national average. But we know that people don't always, when they're on faculty, they don't always stay. They don't always get promoted. And so I think, as Dr. Capers said, that we can't just assume that things are going to happen. We have to be very intentional. And I'd like to talk a little bit about a pilot program that we've done within our division. So first, in our division of general medicine that's based at Grady, it's about 50 of us. We are the most diverse division within our department, first of all, but we have a very intentional program where we support and do quarterly reviews of every single faculty. So again, whether it's imposter syndrome, we don't wait for people to come to us to ask for the raise, to ask for support. We look at every single faculty member to see, are they eligible for awards? When are they ready for promotion? And we have had unparalleled success. About 46% of our URIM faculty are at senior promotion levels. We have, for example, Dr. Manning and myself, Dr. Higgins, 3 full professor women in our small division, where there are only probably 300 in the entire country. And similarly, about 67% of our women have been promoted to senior levels. And again, that is unparalleled across our department and across the Institute of Medicine and Academia. And so I think it is possible, but it doesn't happen by accident. We have to be intentional and provide the support for that to happen.
Okay.
I think thinking also about the as Dr. Bussey Jones mentioned, the root cause for every person is going to be different about why they're leaving. But what we certainly know time and time again is that when people don't see an opportunity for advancement, that is what causes many people to abandon ship when it comes to academic medicine. I think many on this webinar listening have felt that tug before, thinking, should I be here? Or you see your near peers who are in private practice making a lot more money and seeming to be less stressed than you. What am I missing? So this process of not having to feel like it's time for you to go up and having someone objectively look at what you have in front of you and say, hey, this is your time. I can say as somebody in Dr. Bussey Jones's division who was on the opposite end of that, I had her look at my materials and tell me, literally force me to go up for full professor. And the imposter syndrome had me personally feeling like, oh, I needed about 2 or 3 more years. So I think really for leadership to take the time to have some objective measures and programs in place that take out of it this whole idea of you having to decide for yourself. I think that's been very, very helpful and successful for us.
We have a really good question here. Current Asian med student here. How do those of us who are not Black or Latinx go about advocating for diversity when I feel like I can't speak to those same stories of racism and my voice isn't the one people want to hear? Sometimes I feel like I don't have the right to talk about racism since I don't have those experiences. Great question.
Yeah, so I'd like to take that on. Thank you for the question. So, everybody has a role to play in battling racism and speaking out against racism, being an upstander, and we very much welcome your voice. But let me say this, I've been thinking about this too. We need to, in this country, do better about our tribalism. And what I mean by that is, what we tend to do is get very upset if something affects our tribe, but if it affects somebody else's tribe, we don't get that upset about it. So, and I'm saying this specifically to say, as much pain as racism and oppression has caused African Americans and Black people, we shouldn't be silent when we hear the bigotry aimed at Asians for the coronavirus, this calling it Kung Flu or the Wuhan virus. We shouldn't be silent about that because we know the sting of racism. At the same point, Chinese brothers and sisters shouldn't be silent about racism against Blacks. So your voice is very welcome. We all need to speak out anytime we hear somebody being oppressed because of their race, gender, or identity. You have it.
And I'm going to be jumping around a little bit because I want to try to get to some different types of questions here. How are you specifically supporting your Black students during this time when we are all watching Black people being brutalized and traumatized so regularly and publicly?
I know a lot of us are, many institutions are doing different things. I think step one is a clear acknowledgement of what has happened. I think careful thought about the language that you use when talking about things that are directly affecting Black Americans, specifically in the times that we're in now. So, for example, getting an email where something is referred to as an unfortunate event is not the same as getting an email from leadership that describes that that Black Americans have been murdered at the hands of law enforcement officials. And so an acknowledgement. I think that many times people feel like it's an echo chamber to send out those messages to students, but students are looking for a clear acknowledgement in a timely manner. And then we also have had town hall meetings for our students. We have a small group system at Emory where every student that comes to Emory is assigned a small group advisor in a group of about 8 or 9 students. And within our small groups, we also unpack these things. one-on-one, checked on individual students. There have been many ways, but a lot of it has to do with what kind of personal relationships that you work at day in, day out, and what the learning climate is like, and whether or not things are psychologically safe enough for you to really have these tough conversations and support students in a time of mourning. I think that is the piece that leaders are now realizing, that Black people are mourning, and acknowledging and dealing with people as if they're mourning, I think has been a real key part to our support. Others, what do you guys have to say?
Flips, we have like 28 questions up, so we're gonna try, and I'm gonna
take it away, Doc.
encourage the panelists to please give us some sharp, brief answers so we can get to as many of these as possible. This is an interesting one. I was curious to hear the panelists' thoughts about addressing overt racism expressed by patients. Thoughts come to mind about patient rapport, therapeutic alliance. Have any of you had any overt expression of racism from a patient?
Yes, so I don't mind taking that on. So one of the things that's really important that will happen is immediately trying to detect, is this a patient that has their faculties about them, right? So if they do, if it's not a mental illness or dementia, then I would hope that we all get to the point where we can say to patients, if they're not in a life-threatening emergency, that here at this institution, in order for us to take good care of you, we're going to treat you with respect, and you've got to treat us with respect. And that simply will not be tolerated. Now, it takes courage to say that, but we need our senior people. In fact, there needs to be a plaque on the wall when patients come in the hospital. Usually there is something, patient's bill of rights, but there needs to be right next to that saying, this is what we expect of you as a patient. You can't spit on us. You can't cuss us out. You can't use bigoted statements against us. So I think it needs to be immediately handled. Now, of course, if I'm running into the emergency room and somebody has a sword sticking out of their head, and then they say, I don't want a Black man, I might let that slide because we got to get the sword out of their head. But if it's a more elective situation, then it's a time for education.
Interestingly enough, out of the thousands of patients that I've taken care of, the only person that ever told me that they don't want to be taken care of by a Black doctor was another Black male. And I found that quite interesting. So I proceeded to put a central line in him without any anesthesia. Just kidding, a little bit. Quick question, do you have curriculum resources and recommendations for building cultural competence among resident trainees? Dr. Bussey Jones, you talk about cultural competence all the time. Do you have any curriculum resources available? Briefly.
Well, there are several resources. The AAMC is a great resource. Society of General Internal Medicine, we worked on a health equity framework about 10 years ago, so it may be a bit out of date now, but I think the AAMC has and refreshes their information. It's probably one of the best tools right now. Yeah, that's kind of what I think. Do you all have any other suggestions?
I think individual institutions, of course, will have curricula. I know for us, we've been building out a curriculum around racism and being anti-racist at Emory. And I think I would say a fast start might be looking to individual institutions. I am very, very impressed with the work that UCSF has done. They have a very robust site with lots of resources on it as well. So I would start by looking at some individual institutions and the AAMC. Also, our professional organizations like the ACP and the Society of General Internal Medicine will have great resources as well.
Okay. I saw another great question. How does one address colleagues when a Black student is deemed not to be a good fit at the residency selection meeting despite excellent scores and letters? And this can be for residency, this can be for faculty position, for admission. How do you address that?
So one of the important things when it comes to selection with gatekeepers is to have a stable team. So the admissions committee is usually a group. I believe that it's really important to have the same thing for residency selection. Sometimes, you know, because people are so busy, for residency or fellowship selections, they might send out group emails, say, who can help us interview? And it's just whoever has time to do it. I prefer it be a stable, set committee because you can train them. So training is very important. And one way to combat the question that was brought up in this question is to have training where we talk about what we're looking for. So what is the mission of our internal medicine residency? Okay, these 3 things we want to see. How are we going to grade those 3 things? And this is how we're going to see. How can you tell if somebody's persistent? What do you look for in their letter recommendations? How can you tell if somebody's a good critical thinker? What do you look for? And this is what we've all agreed we're going to look for. That way it kind of cuts down on kind of subjective things like this person isn't a good fit, because what do you mean they're not a good fit? We said we wanted these 3 things in our trainees. They've got these 3 things. So it looks like they're a good fit to me. So training of the selection committee.
I would just add to that. I think that's really important, this sort of standardization of the process as much as possible. I was thinking about that in my role as a leader. So when I first started doing, let's say, evaluations, annual evaluations, I was evaluating, a senior person who had been here, who had hired me and recruited me. So that felt strange. But then even more hard, I think, was evaluating people like Dr. Manning, who was a friend, and I wanted to, this is my girl. So I wanted to, maybe I didn't want to give her evaluations or be more subjectively drawn to her and give her great evaluations. So standardizing a tool and the ways that Dr. Capers mentioned, where you say, what is a 5 or what is accomplished, and sort of put in there the check mark. So for example, for scholarship, it means this many papers or this many grants. And so everyone has an understanding of what it means to be a quote unquote good fit, or what it means to be, be culturally competent, or whatever the measure is that you're looking at, to do what you can to standardize that.
Great question here.
Dr. Jones, there was an earlier question that it looks like Dr. McFarland asked, and I had answered part of it privately, and it was just something that I'd like the other panelists just to mention quickly on. And it is about, he mentioned that that the author Ibrahim X. Kendi is not a fan of the term microaggression, because, and he's the author of the book How to Be an Anti-Racist, for those unfamiliar, but felt that the word is not strong enough because the mosquito bites are not micro. They are in fact far more than that. My response to him, and he asked in his follow-up question to just hear what the other panelists thought as well, but my response was that it is a word that is criticized by a lot of people on both ends. I do think it is a word that is disruptive, though, and I think that as we think about moving toward change, I think ideally something that identifies a problem and causes a disruption in us to have those conversations and that critical reflection, I think is meaningful. But I can certainly see the criticism and how, as somebody who has received microaggressions before, how it doesn't feel so micro to me. So just wanted to quickly acknowledge, since been so thoughtful about the question, to see if others had another thought.
Well, so for me, so there's a lot about terminology. I'm big on communicating, and so I'll be honest. As long as what you're saying is not offensive, then I don't get too hung up on terminology. I mean, just last week somebody was saying, don't use vulnerable populations. Now they're saying don't use microaggressions. Don't use this term or that term. Okay, tell me what you would like for me to say. To me, as long as you're communicating the idea to me and you're not being offensive, I don't get too hung up on specific terms.
Speaking of terminology, we have a question: implicit unconscious bias. People have pushed back on me. I lead IB work in New York City public schools and said that IB minimizes the effects and harm of racism. Everyone has implicit bias, but not everyone is a racist. How do you address the distinction? So implicit bias versus racism, what's the difference?
Well, so the difference is just as they pointed out, and Dr. Bussey Jones did a beautiful job defining this. The isms, racism, sexism, homophobia, you lump the isms, the ageism, those are explicit. So if I don't like somebody because of how they look, I'm aware of that. That's not an implicit bias at all. as Dr. Bussey Jones said, the implicit biases are outside of our awareness or outside of our control. So when we talk, that's why this is labeled racism and bias in medicine, because implicit bias is different from racism, which is an explicit bias. However, both of them are playing a major role in healthcare disparities and what we see going on in the country today.
And I see a racist as someone that actively does something to negatively affect the other races. I mean, races, because you can, again, you have your implicit biases, but as long as you don't do anything actively to prevent me or someone from a different race, you know, you just have your implicit biases. But the minute you do something to try to prevent someone else from doing something, that's when I think you start stepping towards racism.
I think the definition, some also include privilege in it as well, saying that if you're in a position of privilege, that is folded into, without getting too far off of the subject, but you will hear that sometimes. It's, you know, so because it often gets pushed back that if you say something like Black Lives Matter, or you are celebratory of Blackness, why is that not racism, right? Whereas, but Black Americans are not in a position of privilege in this country. That could be its own webinar though. So I'll move forward.
Another question, for those of us that work with other physicians that are not receptive to change, where do we start? How do we convince them to get on board with increasing diversity and being anti-racist?
So
yeah, Dr. Bussey Jones, tell us.
well, I'll start. I don't know that I have the answers here, but I think that we have to start with assuming positive intent. And that is where I'm a glass half full kind of person. We've been having these conversations bolstered by the unfortunate events and structural racism that we can see, everyone can see and feel right now, that's leading us towards and propelling us toward these difficult conversations. You know, I do think that that we also have to look at numbers and hold people accountable as well, especially in leadership. So the first step is to make sure that we all have an understanding. But for example, if you are a leader and every single person in the pipeline below you is a white man, or you know, things aren't changing after you've had these initial discussions or these lectures or these workshops, then we have to begin to think about, as Dr. Caper said, what is our institution about? Are we being intentional about this? And so I don't think at our institution we have gotten to that point yet. We're just having these conversations, assuming good intent, and then moving forward from there. But I would love to get the other panelists' thoughts about that as well.
So what I would like to say is that I have found success when we get pushback about the importance of enhancing diversity, and a part of that, of course, is having a climate where diverse people can thrive. Is by going to the evidence base. So as physicians, we love evidence-based medicine. If you're a pharmaceutical rep and you call on me and you say, hey, use this antibiotic because it's better than that antibiotic, what I'm gonna say is, show me the data. And it turns out there's a robust database showing that diversity in medicine improves outcomes. One of my favorite ones just came out by one of my favorite authors, Dr. Saha, that actually showed when you show heart patients videos of people playing the role of doctors recommending heart surgery, that the Black patients are more likely to consent to having a heart surgery if it is a Black doctor recommending it than if it's a doctor of another race recommending it. That's one of many studies we could quote. So when we're trying to get people on board to fighting racism and bias in medicine, everybody wants good patient outcomes. Everybody wants to help their patients live longer. So we need to convince people that diversity actually improves outcomes, and the data is there. So that should be a part of your trying to get people on board, being very evidence-based.
Okay, just quickly again, I want to encourage everyone to please answer the poll question that tells us which organization or affiliation you're a part of. We have a question from, how do residents challenge racism from senior surgical colleagues, but concerned about career and future job prospects if seen as a troublemaker? Since I am a surgeon, I'll speak to this one first. That first of all, surgery is so hierarchical, it's hard to delineate, is it a racial issue? Is it just the fact that you're lower on the totem pole? So that is a difficult challenge. But what I would say is you have to, first of all, have open conversation. Don't be afraid to dialogue with an individual, but you will also need to have advocates in your corner, because there are times, again, when you don't know what's necessarily happening behind the scenes. It may be a racial issue. It may not be a racial issue. But I think open communication and dialogue with you and that person, first of all. But I do think surgery presents a particularly difficult type of situation, because, you know, those surgeons can be difficult people to deal with anyway. Let's see. Trying to get a really different kind of question. I am getting a lot of questions about my mentoring program next week. And what I will do is I will send it to Mr. Blanding, and he can email a flyer and everything out to you, so that you can have that. Yes, this will be available as a recording. Okay. Does racism include intent? I think we were kind of alluding to that earlier. Anybody want to comment on that?
The short answer is yes. There's more intention. So you were talking about action, Frank, that, you know, there's some action around, they have to do something to impede a person of color, but it doesn't necessarily require that. So just someone speaking it out loud, you know, you heard the police officers talking about things in their car, using the N-word. Those are things that are actively racist, even if there's no action around that impedes another person, as opposed to the implicit biases where they're in the backs of our mind. And in fact, when we talk about race or gender or other things, we would actually say the opposite of that. We would not sort of claim it, but they are still, in fact, there. And as Dr. Caper said, unfortunately, having an impact potentially.
Dr. Capers, I think I have one of your former, let's see, faculty colleagues. What are your go-to resources for discussion of privilege and racism? And thanks to Quinn for teaching me well during my time, former OSU Medical School Admissions Committee member. I'll go ahead and mention that person, Kim. I won't say the last name, coming from Kim.
Yes. Yeah. Well, hello there, and thanks for tuning in. So if you don't mind, Frank, the question again was what?
What are your go-to resources for discussion of privilege and racism?
Oh my goodness! I mean, there are many. There's a very nice book out now about how to be anti-racist. There are, you know, I love, even though this is not necessarily talking about.
Dr. Capes, can you just talk about that concept of anti-racist? What a lot of people may not have heard that term. Can you kind of just talk about that?
Yes. So we've talked about what racism is. Racism is the thought or belief that somebody, on the basis of their race, is less deserving, less intelligent, overall just less deserving of an opportunity to pursue happiness. To be neutral, to say that I am not racist, and really you may not be, we're kind of beyond that now. And what we need in society, we need you to be actively the other way, anti-racist, pulling people up, showing that there is value in all things, and actually looking at your language, your actions, your structures, your institution, and seeing where it can be racist, and actually trying to go, I'd like to say 180 degrees in the other direction, whether that's curriculum, how we teach, our hiring practices, our contracts for the people that come and paint the buildings at our medical school. Being anti-racist is taking a stance that sees the racism and tries to do exactly the opposite, so that we really pull people up. So I like that resource, and I also like The New Jim Crow by a lawyer, which really talks about kind of the prison industrial complex, and how racism continues to fuel kind of othering, particularly of Black men, but really also Black women, and how, you know, I was talking about a kindergarten to medical school pipeline. There's unfortunately a kindergarten to prison pipeline that a lot of people make a lot of resources off of, and it really plays a major role in keeping African Americans in kind of an oppressed posture. So those are two that I would suggest, and I'd love for my co-panelists to suggest some more.
I'm a big fan of audio resources as well. I know that my colleagues are as well, but a must listen, I believe, is a podcast series. It's called Scene on Radio, SCENE on Radio. And this particular season is called Seeing White. It's about 12 episodes. It is absolutely brilliant. And it was one of the most transformative things I've listened to learn about the history of whiteness in America. And it helps, I think, for people who wish to be anti-racist, understanding how we got here. Many have watched Ava DuVernay's 13th. I think that's a really important thing to listen to understand, as Dr. Capers was talking about, that kindergarten to prison pipeline that is making people very rich and having a firm understanding. And then if you want to read some fiction, but that is historically rooted and extraordinarily helpful for you to see the longitudinal experience of Black people in not just in America, but before they got here. There's a book called Homegoing by a young Black woman of Ghanaian ancestry who went to Stanford, actually. And the book is, it chronicles the start from a family in Ghana. One person in the family stayed in Ghana, and the other person was taken into chattel slavery. And every chapter moves through a different generation, and then ultimately the two parts meet again. It is brilliant. It will teach you about convict leasing. It will teach you about post-Reconstruction, about all the things, the real social despair, the social determinants of health, and how it really has affected our patients and where we are right now. So I think those are some resources that you can listen to as you're moving between hospitals and on your way places, that really change the way that I think.
And Dr.
right.
Do you want to share about your resource, or that's coming up as well? Just to give a shout out, your podcast.
So there's a podcast called the Nocturnist podcast, which is organized by a woman by the name of Emily Silverman, a physician out in San Francisco with UCSF. However, as a special series, I am working along with another physician, Ashley McMullen, on Black Voices in Healthcare, which is under the platform of the Nocturnist podcast. And so we just actually listened to our first rough cut today. And so we're moving along with it. So please stay tuned for that. And also, we are still collecting voices of Black physicians and people in healthcare who wish to kind of lend their voice. Dr. Capers is smiling because I emailed him and asked him to do it. And anybody who's listening, I would love for you to still participate. But that's coming soon, and our first episode is supposed to drop on June 30th.
It is now 7:58. We're supposed to have a hard cutoff at 8 o'clock, but we have 2 or 3 more very interesting questions that hopefully we can get to. So very, 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 very brief answers, please. One of them is interesting. It's someone from Grady, and they talk about, in light of the police brutality, any suggestions to how we treat some of the incarcerated patients at Grady. This is just not just at Grady, but any hospital. And we've seen how some of the patients are treated, left out in the hallway, not attended to. Any very brief suggestions on how ways that we can better treat those patients?
Just with humanity, with everything that you have in you, and that's what we always have to do. You know, Grady is a county hospital, so it's overcrowded. You know, and so you might have what this person just described, but that doesn't mean that you don't treat the patient with your whole heart. So just treat them like a human being. Everything you have in them, everything you have in you.
This is from a patient that's applying this cycle.
Do your own implicit bias, do your own implicit association test and figure out what your own biases are, so that you can mitigate your own biases and be actively working against them. I think that that's another place where we can protect our patients who are incarcerated, because we probably have a strong automatic preference for patients who are not chained to the bed, right? So keeping that in mind and recognizing when you are tired or at risk for your biases coming out, I think that can help too.
This is from a student that's applying this cycle, and they say, how do I ensure through Zoom, since I likely cannot visit the campus due to COVID, that the school has a right intentions environment for diversity and inclusion for me and other students of color. One of the things that I always tell the students when I talk to them is there are some schools that are diverse because they want to be, and there are some schools that are diverse because they have to be. And you want to choose that school that's diverse because it wants to be. And you can find out by talking to other students, by talking to faculty. You just have to really talk to several people since you can't get that gut feeling by visiting. But that's something that we will talk about on next Tuesday. So I think we are beyond, it's actually 8:01, so we're going to have to wrap up. Again, I want to thank our guests, our panelists for joining us for this joint presentation. Please be sure to go to the poll question and answer where you're from. Again, we want this to start some conversation. One of the things I was going to suggest that we do here in Atlanta for our other medical associations, Medical Association of Atlanta, Medical Association of Georgia, where that's where a lot of our white colleagues and counterparts are members of. Just like having a pen pal, we would like to start a discussion, have a pen pal or someone that we can talk to, or small group sessions where we can actually sit down and talk, because until we start to do that, we're not going to change anything. So again, any very quick parting shots from our three panelists, very briefly.
I'd just like to say thank you for asking me to be involved. So I have so much respect for Dr. Bussey Jones, Dr. Manning, Dr. Jones, Dr. Hubbard. I'm just meeting, but respect for you too, and to John Otis. So thanks for inviting me.
I will just echo that. Again, very excited to be a part of this conversation, and I hope and I know that it won't end here. So looking forward to what's to come.
And I'll just say thank you as well, and just recognize that this is a longitudinal walk that we're taking. It's a long game. You will get tired. Be kind to yourselves as you're learning. And for our colleagues, please avail yourselves to others so that we can do this work and keep having these conversations outside of our own tribes.
So on behalf of the Atlanta Medical Association and Emory University Department of Medicine and the GEAR program and RISE, and for everyone that is on this event tonight, we thank you for joining us. This will be available as a recording, and stay tuned for the next one. Thank you again.
Bye.